Well, hello and welcome to all of our gold viewers here today. I'm Fiona Lang Sharp, IPCLC Director of Communications and MC here at Gold Learning. Well, sitting down with me here today is Robyn Merkel-Walsh. She is going to be with us live for our Gold Learning Tongue Tie Symposium coming up here September 14th and 15th. And we're very excited to be sitting down with Robyn here today. So, Robyn, we're going to go and talk about your presentation in just a little bit here. But of course, I want you to get a chance to introduce yourself and tell folks where you are in the world and what's life look like for you right now, day to day.
Hi, thanks so much for having me, Fiona. It's an honor to be included in this Gold Symposium. Well, as you said, I'm Robyn Merkel-Walsh. I'm a speech pathologist and certified orofacial myologist, and I'm also a speaker, author, and consultant for Talk Tools. I work for a public school here in Ridgefield, New Jersey, in the United States. And unfortunately, as many may have seen in the news, New Jersey and New York and Connecticut were hit the hardest with COVID-19.
Mm,
So on March 13th, I went to work. Little did I know it would be the last time I stepped foot in the public school building for 5 months now. It's been since I've been back. But we pretty quickly transferred into a teletherapy model, which I did as well in my private practice. And obviously, there are some challenges that you face with this because when you're working with oral motor disorders, feeding disorders, tethered oral tissue. This lends itself to very sensory, motor, tactile based therapy approaches. We are in a little bit of a better spot here, certainly by our numbers. Our rate of transmission here is a little over 1, where it was much, much worse than that. So our governor has lifted some of our restrictions, and we can once again attend things like dental visits and speech therapy and see our doctors. Some
right.
day camps have opened, outdoor dining. So that's helped somewhat. My model in my day-to-day life here is I do come into my private practice office every day and I
Hmm.
conduct teletherapy for the school system in the morning and early afternoon, and then I transition into my private practice. I am seeing a handful of kids here and there. The PPE and the parameters of disinfection and sanitation are very, very intense. And I have a very rigorous COVID screening, so there's very few people that make it past the front door. But as
Right.
we know, when we deal with infants, sometimes they just need to be seen, and we are
Right.
essential workers.
Yeah.
So that's what my day-to-day life looks like. I'm still a practicing clinician, 6 days a week, sometimes up to 12 hours a day.
Right, right. Busy then. I mean,
Yeah.
needless to say, there's lots going on for you. And it's really nice to hear how you were able to adapt quite quickly. Was that because you were seeing your private practice clients somewhat online, or was it just something that you were able to do?
I had never done teletherapy
Wow.
therapy before, but I am a very proactive person in terms of everything research, clinical. If I don't know how to do something and I
Hmm.
know that the children need it, I go figure out how to do it. So I did a lot of free online learning. Um, the first month, I was really not seeing anyone.
Right.
School was open, but it was remote learning and
Yeah.
Google check ins before it went to live therapy. So I took it upon myself to trial about 6 different platforms, do tutorials, do webinars, things of that nature. And what I found most rewarding of it, and it really taught me a lesson about the therapeutic process, is even though in my private practice, my parents always observed my sessions and I assigned them
Hmm.
homework, I got them on the screen and figured out very quickly that they really didn't know how to execute these techniques.
Oh,
So
right.
the greatest thing that has happened is the ability of the parent to connect to the child and become
Mm,
the therapist at home. And
right.
the children just love this attention from their parents, and the parents feel more confident and more in tune to the children's needs. So I will
Right.
keep teletherapy as an option indefinitely.
Sure. Wow, that's amazing. Well, I mean, the good things that have obviously been able to apply, during and finding out what telehealth looks like for many of us, and the adaptations that we have to make. All right. Well, let's jump in and talk a little bit about some of the products that you have produced. Like, there is an extensive list of not only resources, articles, contributions to books that you've done, Robyn, but you also belong to many associations. And really, as you said, you're very proactive. Can you share a little bit some of the highlights of what you've just really enjoyed,
Sure.
participating into the community?
So, um, I graduated in 1993 with my undergraduate in communication sciences and disorders, and I was the
Hmm.
last graduating class in New Jersey. It's actually back now, but they stopped offering it as an undergrad program because the graduate schools were so limited that they were matriculating all these speech therapy candidates that they had nowhere to put them.
Hmm.
So I had the pleasure of not only being awarded an emergency certificate so I could work while I was going through graduate school, because I put myself through school, but an
Sure.
aunt who's a speech pathologist and got me
Oh.
involved with oral motor very early in my career.
Mhm.
One of my first 3 lectures that I went to see were Pam Marshalla, Diane Barr, and Sarah Rosenfeld Johnson, who are the fairy godmothers of oral motor therapy and feeding therapy. So I became very passionate early on about working with muscle and motor-based disorders in the pediatric population.
Mhm.
And I was using a lot of talk tools. Back then we were called Innovative Therapists International, and I contacted Sarah with some ideas that I was toying around with, being in the public school and seeing that a lot of these children had muscle-based issues, tongue tie, craniofacial issues.
Mhm.
And I started doing very intensive training with talk tools, and I've been lecturing for them since 1999. My first
Wow.
endeavor was actually in myofunctional therapy because
Mhm.
I was in the school. I was trying to help children overcome tongue thrust disorders. And
Right.
that's where my passion began for tongue tie.
Mhm.
Because many of these children in the public schools are being diagnosed with developmental speech disorders when in fact they have structural restrictions.
Right.
So I have on and off over the years been involved with the International Association for Orofacial Myology.
Mhm.
And with my partnership with Lori Overland, Lori was teaching and I was teaching, and I was already writing books that went with my courses. And Sarah really wanted Lori to write a book that went with her feeding course. And
Right.
Lori's just not, a writer per se. So I teamed up with her, and what started out was going to be me basically writing about her class, and it turned into so much more because I had the aspects from my myofunctional background to add. And um, since I'm the board chair of the Oral Motor Institute, which was handed down to me by Diane Barr and Pam Marshalla, who passed away a few years ago,
Mm.
um, I like to present the evidence base. So that
Right.
book was a manual turned into actual professional text. And
Mhm.
from there, it's really, just exploded and boomed in terms of webinars and, moving on to the tongue tie book, the functional assessment and remediation of tethered oral tissue with Lori, and all the little things that branch out from that. Since
Right.
we decided to write that book, we've designed a structural assessment guide, we've designed a 5-step screening tool, and just recently we expanded our 1-day class into a 2-day class, which we're launching this September.
Exciting.
So there's a lot going on with that. And then behind the scenes, I do a lot of work with various organizations to help advocate for oral motor and oral facial myofunctional therapy, and especially with networking and being doing a lot of interprofessional training while remaining to stay within scope and ethics. So
Right.
I consult, like I said, behind the scenes for a lot of different organizations and school districts and things of that nature.
Absolutely. Wow. I mean, it is extensive. As I said, for those listening in, please, go check out the website. You can see all the details of Robyn's, not only her abstract. We're going to be talking about that in a moment, but also, of course, her bio as well. You can read up on all those things. Just it's wonderful to hear. I know how passionate you are, Robyn. All right, we're going to jump in. Just briefly talk about your presentation. And again,
Sure.
just a quick reminder for folks listening in. So you can go to the website right now, goldlearning.com, and you can click on the link for our tongue tie symposium. Robyn is going to be with us live on September 15th, and she's going to be sharing about understanding the variations of active wound management and neuromuscular re-education. So, Robyn, tell me just briefly, like a little teaser, what should we expect on the day? What are we looking forward to hearing about this presentation?
Well, there's often a lot of confusion because frenectomies can be done two ways. They can be done with a laser or they can be done with a scalpel slash scissor. And the pre and post-op care could
Mhm.
vary for those two procedures based on having stitches, not having stitches, primary and secondary healing. And there's a lot of professionals now ranging all the way from IBCLCs, as you know, to PTs, OTs, speech pathologists, craniosacral therapists, licensed massage therapists, in trying to help these infants, children, and adults pre and post operatively.
Right.
And it's really important to understand that there's two phases of treatment, one being devoted to the wound itself and guiding its healing and preventing scarring reattachment. And
Hmm.
then there's function and the task analysis of the sensory oral motor skills that are required for nursing, for speaking, for feeding, and looking at the patients and saying, hey, this is where the deficit is. What is the prerequisite oral motor skills to map out um, sensory motor information to help with those functional skills? Because frenectomy alone, as we know, does not automatically cure the functional deficits that our
Right.
patients face.
Absolutely. Well, that for me, that's everything that I need to know next. I mean, I'm working with clients in my small private practice right now, Lori, Robyn, and that's the thing is that there is so many of these variables, and I also find that the practitioners that I've got doctors who are doing scissors, I've got dentists who are doing laser, but there's not a lot of communication happening, in all of these care and management. So I'm looking forward to hearing some more from you on the day. Excited to hear how also you're collaborating with other professionals, so that we can communicate well with each other as well. Well, thank you so much, Robyn, for being with us here today. And again, just a quick reminder that for all of you listening in, you'll be able to join Robyn live on September 15th. We will be having a live Q&A after her presentation as well, understanding the variations of active wound management and neuromuscular re-education. Thank you so much, Robyn, for being with us here today.
Thank you. Thanks for having me.
And thanks again to our listening audience. We'll look forward to having you back all very soon. Bye bye for now, everyone.
Bye.